Okay.
Hello, everyone. My name's John Riker. I'm an interventional radiology consultant in Newcastle, and I'm delighted to introduce the panel for this session. This, I should say, is one of a series of webinars that the BSIRT and IR juniors are organizing of journal club webinars. So the topic of the webinar today is the second asymptomatic carotid surgery trial, or ACST-2, which was initial results of which were published in the Lancet in September of last year. So our panel today, we've got Talani Lewis, who's a senior IR trainee based in Merseyside, Ralph Jackson, who's a IR consultant colleague of mine in Newcastle, Trevor Cleveland, who's an IR consultant in Sheffield, and many of you will know as the from his recent stint as BSIR president, and Jerry Stansby, who's professor of vascular surgery also in Newcastle. Now we're lucky that Dr. Jackson, Dr. Cleveland, Professor Stansby all have a lot of experience both in carotid intervention and also have significant involvement in many of the big carotid trials that we'll hear about today. So I'm sure they'll have some very valuable insights. So the plan for the session is that I've got a very brief, very basic talk about treatment of carotid stenosis. That's a sort of scene setting talk. Then Talani will take us through the results from the ACST-2 study, and then hopefully plenty of time for discussion with our expert panel after that. So please feel free at any point to put questions on the chat. And I should add that Shian Patel, who's the BSIR trainee or BSIRT president, is here, and he'll be collating questions from the audience and putting them to the panel later on. I'll try and keep the session to 1 hour, so we shouldn't go much beyond 7:30. So great, I'll load up my talk. Great, starting at the end there. Right, so hopefully you should see my first slide. So with the introductions over, I'll start things off with a very basic introduction to today's topic, which is treatment of carotid artery stenosis. So starting at the beginning, why are we bothered about carotid stenosis? Well, we know that the narrowing of the carotid arteries predisposes people to ischemic stroke. The typical picture is that atherosclerotic plaque builds up at the carotid bifurcation, narrowing the lumen of the origin of the internal carotid artery. And once the narrowing becomes severe enough to have a significant effect on the flow of blood in the artery, then there's a risk of ischemic stroke in the territory it supplies. This might be due to blood clots forming on the plaque or bits of the plaque itself becoming dislodged and embolizing to the brain. Treatment for carotid stenosis is all about minimizing risk of disabling or fatal stroke in particular. Broadly speaking, we can think about non-operative and operative strategies for managing carotid disease. Non-operative management, which it's important to consider for every patient, encompasses lifestyle interventions, smoking cessation, diet, and so on, and also medical treatments, including antiplatelets, lipid-lowering therapy, and glycemic and blood pressure control. Operative management, which is appropriate for selected patients, is our focus for this session, and it boils down to two main strategies: carotid endarterectomy, which is an open surgical technique where the artery is directly cut open and the plaque is removed, or stenting, where a metal cage or a stent is inserted under X-ray guidance to prop the artery open. We define carotid stenosis as symptomatic if a patient has had an ischemic stroke or TIA in the territory supplied by the stenosed artery within the last 6 months. And occasionally definitions are slightly different, but historically we've gone with 6 months. Anyone else found to have a carotid stenosis is deemed asymptomatic, even if they've had a stroke in the relevant territory, which was more than 6 months ago. And I'm sure we'll touch on this as we go through the session, but symptomatic status is important as it alters decision-making around choice and timing of treatment. The basic principle here is that once you've had one stroke or TIA in the presence of carotid stenosis, we know that you're more likely to have another, and that risk is highest in the couple of weeks after the first event. So to lend a bit of context to the ACST-2 study, which Talani will take us through in a moment, I'll very briefly run through the most influential trials to date, which form the core of the evidence basis for decision-making in carotid disease. Lancet, published in 1991, was very significant. It was the first trial to show significant stroke risk reduction for endarterectomy versus medical therapy alone in symptomatic greater and ECST-2, which came a few years later, ECST, showed very similar results in European cohort. ACAS and ACST-1 showed that endarterectomy significantly reduces stroke risk in asymptomatic patients. And CREST from 2010 was the first major trial of surgery versus stenting and showed no significant difference in long-term stroke prevention, but more perioperative strokes in the stenting group and more perioperative MIs in the surgery group. Interestingly, subgroup analysis showed that men in the stenting arm of the study fared better than women in terms of perioperative stroke risk. And ICSS from 2014 showed similar results, higher overall stroke risk after stenting, but the excess strokes in the stenting group were usually or mostly non-disabling. So a quick word on quantification of carotid stenosis. There are lots of different systems for measuring stenosis, and we tend to measure stenosis either using duplex ultrasound, which measures velocity change through the stenosis, or CT and MRI, which directly assess the reduction in caliber of the vessel. All of this can be quite confusing, but it's worth mentioning that in the UK, we tend to follow the Lancet concept, which is that a stenosis is defined by the reduction in diameter relative to the healthy downstream vessel. So to summarize, operative intervention has been shown to reduce long-term stroke risk both in the symptomatic and asymptomatic patients with severe carotid stenosis compared to medical therapy alone. But it's acknowledged that decision-making can be more complex in the asymptomatic group, as the relative benefits of intervention are probably smaller. We've got evidence that stenting and surgery achieve similar rates of long-term stroke prevention, but with different perioperative risks. The ACST-2 study published in the Lancet last year is important as in terms of patient numbers, it's both the biggest RCT to date of stenting versus surgery, but it's also the biggest trial ever involving asymptomatic patients. So thanks everyone. With that, I'll finish and hand over to Talani.
Thank you very much, John. I'm just going to share my screen. Okay, hopefully everyone can see the presentation. Okay, my name is Talani Lewis. I'm a registrar based in Merseyside, Northwest School of Radiology, and today I'm going to be talking about the ACST-2 trial and the results from that, comparing carotid artery stenting versus carotid endarterectomy. So John has already touched in significant detail on the previous studies and seminal papers leading up to where we are today. So I'm not going to reiterate the point too much, but essentially, this is a follow-on paper from the ACST-1 study, which showed that there was benefits in treating patients with high-grade asymptomatic carotid artery disease with surgery versus no intervention. There have been other trials that have gone on to compare stenting versus endarterectomy in both symptomatic and asymptomatic patients. And they've shown that there's similarity of the long-term protective effects of both stenting and endarterectomy. However, what we do know is that prior to this particular study, the available data for asymptomatic patients was lacking. And a number of, there have only been 7 trials prior to this, with a total of about 3,000 plus patients that have looked at comparing stenting versus surgery in asymptomatic patients, and that the available evidence wasn't sufficient to recommend stenting as an alternative to endarterectomy. So hence we have this particular study. The aims and objectives in ACST-2 were to compare stenting with endarterectomy in asymptomatic patients with severe stenosis, and also to consider the results of this study in the context of those from all other trials comparing these 2 procedures. The primary objectives, first of all, to look at the peri-procedural risk, i.e. the immediate risk of MI, stroke, and death within the first month after intervention, and compare the 2 groups. And then to look at the more long-term risk of stroke between the 2 groups, and specifically they were interested in disabling or fatal stroke. So it's an international multi-center randomized control study taking part in over 33 countries with 130 hospitals participating. These are the top 4 recruiting countries by patient number: Italy, UK, Serbia, and Germany. Patients included were patients with severe unilateral or bilateral carotid artery stenosis, and they had to have at least 60% stenosis that was detectable on Doppler ultrasound assessment. They also had to have no ipsilateral carotid artery symptoms, or at least none for at least 6 months. Both the physician and the patient had to agree that some sort of intervention was required, but had to be uncertain as to what type of intervention to choose from. Patients excluded were those with ipsilateral intervention previously, those deemed unsuitable for carotid artery stenting, either because of morphological concerns such as calcification, extensive calcification, or anatomical concerns, e.g. vascular tortuosity, and those deemed unsuitable for endarterectomy because of surgical inaccessibility. Also, on top of that, patients with high procedural risks, patients with high risk of cardiac emboli, and patients with any major life-threatening conditions were excluded. So to participate, collaborators had to prove successful experience in either of the allocated procedures. There was a technical management committee that would review their track record, and they had to demonstrate that they had less than 6% stroke and death risk for the symptomatic group of patients that they treated, or less than 4% stroke and death risk for the asymptomatic patients. And the grade of carotid artery stenosis was assessed using locally validated criteria. It's not entirely clear what that is, and that might be a point of discussion further on in the talk. The procedures, there was no stipulation as to the sort of techniques that operators were to use either in the stenting or the surgical group, as long as in the stenting group, the devices had a European safety approval that they were allowed, they were permissible, and surgical preference was also permissible with regards to whether or not there was shunting or patching, or regional or general anesthesia was used. All patients were assessed neurologically during the hospital admission or within 30 days. Patients had medical management, which was down to the discretion of the clinician, but usually they were prescribed antithrombotic, antihypertensive, or lipid-lowering therapy. And these patients went on to have follow-up after a month after their treatment and yearly after randomization for up to 5 years. So we're interested in the immediate peri-procedural events within 30 days, as I've already mentioned, mortality and morbidity with respect to infarction, myocardial infarction, and stroke, and also non-procedural stroke after 30 days and up to 5 years. So for myocardial infarction, the patients had to have symptomatic disease and either a biomarker elevation or ECG changes that prove that there was an MI. And for stroke, the patients had to have been at least symptomatic for 24 hours, confirmed by imaging and classified. And the outcome of the stroke was graded using a modified ranking scale, which you can see on the right. So from 0 to 6, with 0 being no symptoms as a consequence of the stroke and 6 being death, with a gradation of disability in between. So as far as the baseline demographics is concerned, there was the computer was used to generate, to allocate the patients into one of the two groups, and there was sort of a 50-50 one-to-one allocation. But this allocation was minimized on the patient characteristics alone, and the aim was to match the characteristics between both groups. So you can see that both these tables show that there's an equal proportion of patients in the stenting or endarterectomy group as regards to the sex, the age, pre-procedure cholesterol, blood pressure, and so on and so forth. So just a flow diagram just to sort of roughly explain what happened with the patients. So you had about 3,625 patients randomly allocated between 2008 and 2020. So you can see 1,800 in both groups. And most patients in either of the groups had their procedures undertaken within 1 year, with a median time to intervention of 14 days in both of the groups. There was some crossover in both groups, and some patients, as you can see, didn't have any carotid procedure at all. Patients were followed up for a mean of 4.9 years, and then there were equal number of patients withdrawing for reasons of consent, and roughly equal number of patients were lost to follow-up. In terms of the sort of statistical analysis, it's an intention to treat analysis with survival, sort of Kaplan-Meier time to event curves plotted for all outcomes, or provided for all outcomes. And then you had log rank analysis was used to compare stroke rates between the two groups over specific time periods. So it's assuming a null hypothesis that there's no difference between the populations in the probability of an event, i.e. in this case, stroke. And then risk ratio or rate ratio analysis was performed for both subgroup analysis for the trial specifically and a meta-analysis of this trial compared to other trials. And this particular diagram here, just to show, because there's some diagrams later on which are relevant, show that so the further away in terms of the risk ratio you are from 1, the greater the effect of an exposure on the study group. So 1 assumes no difference in exposure on the study group, and lower than 1 suggests that there's a lower risk in the exposed group, and greater than 1 assumes there's a higher risk in the exposed group. And they undertook a meta-analysis of the results from their trial in conjunction with those from other trials found using a literature search strategy from a 2020 Cochrane review. So I'll try and sort of briefly summarize what was found. So as far as the immediate sort of peri-procedural hazards are concerned, within 30 days, they found a small excess of strokes following in the stented group versus the endarterectomy group. So with regards to non-disabling stroke, the rates or proportions were 2.7% in the stented group versus the surgical group of 1.8%. For myocardial infarction, there was a small excess of myocardial infarction following surgery compared to stenting. The rates of death, the proportion of deaths was similar in terms of the percentages. And the overall risk of death, the disabling stroke, was again similar between both groups. For non-procedural strokes, so strokes occurring after 30 days in the follow-up period, patients receiving the slightly greater number of strokes in the stented groups compared to the surgical group, 5.2% versus 4.5%. But I mean, suffice to say that these differences were not considered to be significant statistically. We've got a Kaplan-Meier curve showing that, you know, I mean, you've got the risk ratio of 0.98, sort of tending to 1, and the values of P are not significant, and there's no difference between stenting versus surgery in the incidence of fatal or disabling stroke which is what this graph is specifically referring to. For non-procedural strokes, based on 91 patients who had strokes in the CAS group versus those in the endarterectomy group of 79 strokes, there's a slightly increased risk of non-procedural stroke in the stented group, but again, this was not considered to be statistically significant. Subgroup analysis, essentially to see if there are any relevant trends between the different characteristics of patients. Some trends are identified showing that endarterectomy was more protective than stenting for ipsilateral ischemia. So this is sort of referring back to that diagram that was shown in the analysis slide, and you can see that for the ipsilateral ischemia, endarterectomy looked to be more protective than stenting. But in the other ischemic groups, there's no difference found. For age, stenting appeared to be, let's just go to the age, slightly more protective than endarterectomy in those patients. CAS appear to be slightly more protective than stenting for patients over the age of 70, whereas those on the age of 70 endarterectomy appear to be slightly more protective. And for the grade of stenosis, stenting strangely appeared to be more protective if the stenosis was 90 to 90%, or less than 70%, with surgery more protective at grades in between this. However, none of these differences were proven to be statistically significant. So that includes sex, age, stenosis, and plaque characteristics. When you compare this trial to the other trials, so the meta-analysis, so in the top half, you've got basically this asymptomatic patient. So trials recruited looking at asymptomatic patients and trials looking at the symptomatic group. ACST-2 suggested that slightly more benefit from surgery versus, demonstrated in this group compared to the other trials. Although, I mean, I would say, broadly speaking, the findings are similar in terms of what their conclusions are. So I think if we summarize, the conclusion we can reach is that the complications are serious complications, certainly are uncommon in both groups, and essentially when performed by operators with quite a good track record and expertise, and they're uncommon to a similar degree. Surgery slightly but non-significantly better than stenting, at least for non-disabling stroke, and the protective effects of stenting and surgery on fatal and disabling strokes are similar in the short to medium term. I would say it's quite a good study. There's randomization, which provides good unbiased comparison of the long-term protective effects of stenting versus endarterectomy. It's quite good. It's double the number of patients in the asymptomatic group in the overall trial data. And their findings are consistent with results from recent registries and previous trials, confirming that both procedures carry similar risk and similar comparable benefits. I was slightly concerned that in some of the statements about grading of stenosis, it's not entirely clear how that took place. They've just said there's locally validated criteria, no independent adjudication, it seems to me. It'd be interesting to know how applicable these results are outside of high volume centers. You had to prove a track record of less than 6% for symptomatic patients and less than 4% for asymptomatic patients. So how beyond, in low volume centers, probably not so applicable. And it didn't seem to me that the data demonstrated which procedure was clearly preferable, for instance, for specific patient subtypes. And whilst the medium term durability of procedures has been established. Longer term protection is yet to be fully ascertained, and I know they're yet to report on patients are still being followed up. And they've not commented to any degree on the cost implications to health services or patients between choosing from one procedure versus the other. That's about it. If there are any questions or comments, I'll hand over to the panelists.
So Tilani, that's brilliant. Thank you very much. A very thorough coverage, and that's great. So I'd like to open the discussion up now, really to our expert panelists. First of all, any comments about what you've heard, and anything you'd like to add about what ACST-2 tells us. Prof. Stansby, you've got your hand up.
Yes, John. I thought that was a fantastic summary of the ACST-2 trial, and also, a good, very quick summary of what preceded it. I mean, I think it's important to look at ACST-2 on the back of what ACST-1 told us, because I think that's quite a helpful thing to do, which showed that surgery was somewhat better than medical management for periods of time or periods of analysis at around about 5 years, because in fact it was worse during the first 2 years. Some very interesting life tables in that paper. And I think the other important study to my mind to think about as well when just thinking about ACST-2 is the ICSS study, which did tend to show, very similarly that obviously in symptomatic patients, that broadly the results for major events and death were similar, but for some of the minor strokes, it appeared to be more in the stenting group. And that was backed up by a sub-study where they actually did before and after MRI scans of the head and showed that the stented patients did have more little areas of infarction, probably sort of microembolic, which really comes back to technique and some of the newer approaches to trying to get rid of those emboli, to try and get rid of those more minor strokes. So I think most of us would now regard stenting as, an important tool to be available, with a bit of debate to be had about individual patients as to who should be stented and who should have the operation. But we are, of course, working within an NHS where it's not that easy necessarily to get a stent, whereas carotid endarterectomy is a provision that every vascular unit and every vascular surgeon is trained to provide.
Dr. Cleveland, fire away.
I much prefer Trevor, actually, but
Trevor.
no, there's a couple of things that that come from that. That was a great presentation. That was very good. There's the question of what happens to those non-disabling strokes in time. I think Jerry's right that most of the trials in both symptomatic and asymptomatic patients do tend to suggest that stenting has a higher all-stroke and death rates, but it is largely down to so-called non-disabling or minor strokes. And if you follow those in time, over a number of trials have shown that they probably mainly resolve. And if you look at the patient's modified Rankin score, i.e. their ability to function 5 years plus down the line, the two groups are pretty much exactly similar. So I think that's one thing. It is slightly concerning when you look at some of those data that whilst it's not significantly different, they fairly consistently show an increased number of non-disabling strokes. But in terms of patient function at 6 to 12 months down the line, they pretty much equalized. The other thing I think we've got to be really careful of is that we don't see stenting and endarterectomy as being necessarily competitive. There are some patients who have a high risk of stroke, whether that be from symptoms or whether that be because they've got a high-grade asymptomatic stenosis. If they're at high risk of stroke, sometimes they have a contraindication to surgery, sometimes they have contraindications to stenting, in which case the patient can still get a benefit because one of those procedures is suitable for them. So it's not necessarily about competition.
Thanks, Ralph.
Yeah, thanks both of you for that. From my point of view, what did this study tell me? Well, it reassured me that at least we weren't harming patients in the short term. And I think that's the point of this first report is it safe? When talking to almost all of these patients with asymptomatic carotid stenoses, the vast majority will not go on to have a stroke. And it's worth telling patients that most patients will not go on to have a stroke. So you're trying to reduce a small risk to an even smaller risk, and knowing that if we successfully treat a large population, then actually it will benefit a proportion of those patients. And when doing carotid interventions, you don't know who's benefited from your intervention, but you certainly know who you've harmed, at least in the short term. So I think the immediate report was very reassuring to our current practice.
Thanks for everyone for those thoughts. I wondered if we could take it back. So something that Talani mentioned is obviously all patients randomized in ACST-2, there was local agreement by the clinicians that these are patients who warranted intervention, asymptomatic patients who warranted intervention. But it's not prescriptive about who should get intervention, which asymptomatic patients should get intervention. So I wondered if we could have the panelists' thoughts about how we make those decisions, which asymptomatic lesions we want to treat, and how we go about deciding when to intervene. I think, Jerry, do you want to come in there?
Yeah, well, just to say in relation to that really I think it's got to be a multidisciplinary decision. And one of the things that actually was functioning within the ACST-2 trial, and I'm not sure if they put it in this paper in the Lancet, was that you had to have a principal investigator who was a stroke physician involved in the decision making. And definitely it wasn't, a surgeon or on their own, and it wasn't a radiologist on their own, it wasn't a stroke physician on their own, it was an MDT approach to deciding which of all the patients you might see would be suitable for intervention as the first decision. And only secondly, would they then be someone you could randomize into the trial. Now, how that worked in practice at different centers could have varied quite a bit because it was a pragmatic trial. They didn't tell you in minute detail how to measure things and do things. But that's the reason they managed to recruit, and they did so well. You could argue that's why it maybe does reflect real world practice. So my comment would be in decision making, we could talk about the generalities of how we pick the patients, but I think we need a multidisciplinary team making the decision. And I think we also need it to be shared decision making, because patients vary enormously in their attitude towards these things. Some people say, no way am I having anything done. And others say, I know I've got a narrowed artery. I really would like to have something done. And just to give some sort of context, in the ACST-1 trial, the 5-year stroke and death rate was, I think, about 14% in the medically managed group and about 8% in the intervened group. So as Ralph said, it's not trivial numbers if you're a patient desperately scared and worried about having a stroke, but these are quite small numbers statistically.
Trevor, I think you had your hand up first. Do you want to come in there?
Yeah, I think it's important for everybody listening to understand, if you look around the world, these are not simple decisions. And if you look at the rate of intervention for asymptomatic carotid disease, if you go to the US, somewhere in the region of, from memory, around 2/3 of carotid endarterectomies are done for asymptomatic disease. If you go to Scandinavia, they almost do none. And what I think that reflects is that different healthcare services offer different priorities, but I think what it also says is that the evidence is by no means clear cut as to who should and shouldn't be intervened upon.
Ralph, did you want to come in?
Yeah, the other interesting thing about the trial is you may be wondering how on earth we found any patients going to the trial. You know, how were we finding these patients with asymptomatic carotid stenoses? So they came to medical attention somehow or other, and a proportion came to medical attention because they did have symptoms, but it was on the other side. Now, what I never actually found out from the trial, although I believe the numbers are relatively small, is how many people had symptomatic events in the contralateral part of the brain, and during investigation for that were found to have an asymptomatic carotid stenosis. Now, I don't remember if Jerry has got any insight onto that, but certainly I don't think it was a huge proportion, but we had to find these patients somehow. And whether they represent the true general public or not, I don't know.
Well, Ralph, I think they almost certainly don't represent the full entirety of the patients out there. And I think it was probably only a small number who hadn't had some reason, such as a stroke on the other side, or actually quite a few who'd been scanned prior to coronary bypass grafting, where we'd picked up a unilateral stenosis that we didn't feel needed intervention for their cabbage procedure, but ultimately they were then discussed for the trial. So, I mean, just to sort of maybe get to the nub of the question John asked about, you know, who should have asymptomatic intervention. I mean, I think most of us would agree that if you're younger and fitter, you're a better candidate than if you're older and unhealthier. And I think that fits with the data from ACST-1, which really shows that until you get to about 5 years, you know, you're probably not going to get much benefit. And actually, at 2 years, the results were no better for intervention over medical management. So I think you've got to be able to try and predict what a patient's likely life expectancy is when you're making the decisions. And I think we're probably also agreed that, you know, the stenosis, no matter exactly how you measure it, and that's often it's actually, I mean, that diagram that we were showing about how you measure for ACST, ECST and so on is very helpful. But of course, that was all designed with catheter angiography images in mind. So none of it really quite applies to the modern approaches to grading on things like, you know, St. Mary's ratios and so on, and velocity changes. So, you know, we can argue about the fine detail, but broadly, I think we'd all agree that if a stenosis is relatively less severe, I'll say less severe rather than mild, because I don't know what that means in this context, then you're probably not going to get as much benefit as if it's more severe. And then I think you do have to plug in things like, if they've had a head scan, have they got any lesions in that hemisphere which may have been asymptomatic, but probably do predict the fact that that's an embologenic lesion. So, you know, I think you have to just put together lots of factors. And there's some cases where I feel very confident in suggesting we should intervene if the patient's in agreement, but quite a lot of grey area cases as well. No pun intended.
Trevor.
Yeah, I think the other piece of evidence that's recently been published, which I think is useful in this, has come from the Oxford Vascular Research Group, who look back at a fairly large number of patients. They got a fantastic setup, and they look back at the asymptomatic patients, and they felt that their conclusion of the study, it was published last year, and I think the Lancet, I can't remember now, was that the high-grade carotid stenoses that are asymptomatic, we possibly underestimated their prediction for stroke. So the high-grade, greater than 70% stenoses on Lancet criteria may have more benefit than perhaps we thought in the past. The flip side is their view was that with modern medical therapy, that the groups with lower degree of stenosis actually would get no benefit, or as Ralph described, some of the harms, particularly in the short term. And the other thing that I think we've probably also got to, and we don't know the answer to, is that we're taking a point in time, somebody's having their carotid stenosis measured on age 8, but we don't know then what happens to that carotid stenosis, whether it's progressive or not. It didn't suddenly appear, so in some degree it must be progressive. The question is whether we should be monitoring those with duplex, which leads you on into the other issue that we've kind of slightly touched on, is that with modern, you must get it through the door. I do, maybe it's my age, but I get through the door offers to monitor my cardiac and vascular health and to pop down to the local school and have a duplex. And I fairly regularly get called by the GP saying, well, they've now come in with this report that says they got a carotid stenosis of 40%. What do I do about it?
I think as a bit of background as well, it's probably worth saying that worldwide, as opposed to what we do in the UK, there's a lot more interest in looking at plaque morphology using duplex and trying to predict plaques that are more or less likely to be risky, which we don't tend to do, but may be a factor in some countries. And I think ultimately as well, one of the key things that usually gets mentioned when talking about carotid stenting is the learning curve, which I think was briefly mentioned, but it's probably one of the most challenging radiological procedures that has a definite learning curve attached to it. And there's quite a lot of data out there about learning curves in carotid surgery. And, I think you've got to factor that into the decision making as well, because if you are a sort of low volume center for carotid stenting, you wouldn't, I would suggest, be as likely to get good results as in comparison to a unit which does a lot of stenting. That's partly an organisational and a political thing as to how you provide stenting if you're going to choose it in more people.
I wonder, Jerry, can I put that to Ralph and Trevor? How do you, I guess, develop a practice? How do you get good? How do you stay good at stenting?
I'm going to very much defer to Trevor on this because he's the UK father or partner father of carotid stenting, if you like. It also helps that when I learned, one of their trainees came to Newcastle to teach me. So a lot of what I learned was what Trevor taught Samira MacDonald, who was an absolute world expert in carotid stenting. How do you keep good at it? Oh, sorry, there's another point I was going to make, and it really pains me to say this, but it is commented on in the ACST paper. The surgical outcomes for surgical stenting outcomes, i.e. stents done by surgeons, were as good as interventional radiologists doing stents. So it does seem that you've got to be the right operator. It doesn't actually matter what your background is. And I think by memory, the big American CREST trial, which included symptomatic and asymptomatic patients, found the same thing. So it helps to be trained well, but then maintaining your skills becomes difficult when one of your referral bases falls away. So we maintained good numbers through recruitment into the asymptomatic trial. Now, since the trial closed, the number of asymptomatic carotid stents I've done in the last 3 or 4 years is fewer than one hand. I don't know if, Trevor, it's different in your end.
Yeah, I think you're right. It was Gary Player who said, the more I practice, the luckier I get. And I think that goes for all surgical, and I use that in inverted commas, any procedure, you're much more likely to get a good outcome with somebody who's doing a lot of them. So, I mean, I think that is an issue about maintaining practice. I agree with you that they're having spent a fair bit of time trying to teach some people to do carotid stenting. They're clearly never going to learn it. And given the numbers that are being done at the moment, then they do need to be concentrated in places to maintain that practice. I mean, the American College of Cardiology recommendations, which was coordinated by the ACC, but involved just about every different group who might be involved in it, would suggest that you need to do somewhere in the region of 50 carotid stent procedures in order to hit the plateau of event rate. And that's once you've got there, maintaining it's a lot easier. You need to do somewhere in the region of 10 to 15 plus a year, and you probably maintain those skills. And that's probably, I think, Jerry, you probably agree, that's not dissimilar numbers to things like open aneurysm repairs. All this kind of stuff are along similar kind of numbers. But getting that practice in place first is difficult.
I wondered, just changing the subject slightly, that it's been mentioned a couple of times, and Trevor, you touched on it in your previous comments. It's the concept that best medical therapy, so all of the trials, the original trials compared endarterectomy with best medical treatment. And we've seen medical treatments improve, more aggressive blood pressure control, better antiplatelet regimens, better statins, and so on. So I wonder, comments really around how improvements in medical therapies change things, and the kind of future frontier of research on that front.
Yeah, I certainly take the view, particularly with asymptomatic patients, that I see that the benefit that we're offering is a bit marginal. I have in my head that we're reducing their stroke risk from 2% per year to 1% per year. If there is a contraindication, be that anatomical or drug therapy or whatever, then I think with the current best medical therapy, I would think that I would not offer them a benefit and would therefore encourage them away from an intervention.
Yeah, I'd agree with that, Trevor, but I think, to get back to what I said earlier, there is a life expectancy thing here as to the younger, fitter patients who might live 20, 25 years are going to have more time to accrue benefits. And I mean, the bottom line is we really don't know about those longer term benefits of the medical therapy and how the progression and so on is going to be prevented. So, we are in a bit of a evidence-free zone when it comes to that. I mean, there is at the moment a move around trying to get some traction for a trial to go back and look at managing some of the symptomatic patients medically, with things like 3 months of dual antiplatelets instead of what we're doing at the moment. So there's a lot of work to be done to know exactly how the modern approach to medical therapy is actually going to impact on longer term outcomes. My personal view, and that's partly extrapolated from other areas such as aneurysm patients and PAD patients, is that what we're doing to some extent is we're pushing the problem back in the sense that the people that had the risk in the natural history when they were 60 are still seeming to get it, but they're getting it now when they're 70 or 75. So I don't think we're actually curing all potential strokes. It's just that we're perhaps pushing it back into a more elderly age group, which is increasingly seen in my clinic each Monday morning, and people who've got multiple morbidities as well, where perhaps some of the issues, like perhaps looking for a lower cardiac risk outcome, might be relevant when it comes to stenting.
That we have a question from the audience that's quite interesting and related to this subject. So Flavius asks, do we have very long-term data around stent patency rates? So the question is, do they last 15, 20, 25 years?
Yeah, the answer is we probably don't. If you're looking at 15, 20, 25 years, I did my first carotid stent in 1995 to 2000. So we don't have 25 years of data from even that, and we're using very different devices now from what we did. So no, we don't have that data. What I would say, and it's a little bit negative for stenting, we do know that carotid stents have a higher restenosis rate than an endarterectomy, particularly if the endarterectomy has been done with a patch. However, the flip side of that, and again, this is all information which we need to gather, is that an asymptomatic carotid stent restenosis does not necessarily translate into a problem to the patients. So just because you find a restenosis on ultrasound or you CT them for some other reason doesn't mean that you need to intervene on it. And again, I wouldn't tend to do that unless there was a reason to.
I would agree with that totally.
I wonder if that's a good point to ask questions around how stenting technology and techniques have moved forward, particularly since the early trials of stenting and surgery, and I guess questions around embolic protection techniques and also stent design. I wondered if Trevor and Ralph wanted to speak a little about that.
Trevor, do you want to take that away?
Yeah. I mean, the first stents that we put into carotid arteries were balloon-mounted stents that were made for the coronary arteries, and they were clearly not really terribly suitable. As time has progressed, we now have stents which are designed to go in the carotid artery. That means a number of things. One is that we need to get them to where we want them. And that requires a sort of a type of delivery system. And we're also looking at stents which are what we call self-expanding, which means that if you compress them, they reopen back up again, which is considered a good thing in the neck, particularly when things do press against people's necks. Add on top of that now, the latest type of stent is to include perhaps 2 layers of stent, one layer which provides some strength to open the narrowing, and the other layer that's almost a bit like a pair of tights, really, which is a very thin mesh, which either lies on the inside or the outside of the stent. The idea being that some of those later strokes that you see in the ACST-2 trial that happen post-procedure may be because of atheroma, which remains in the carotid artery, prolapsing through the struts of the stent, and therefore providing an opportunity for platelets to adhere to that bit of atheroma and to embolize the brain and cause a stroke. So, of course, if you have an endarterectomy, all of that atheroma is removed. So stents have changed enormously. And as an aside, I think I have no industry involvement, but a lot of these technological advances have been because industry have seen a potential to make money out of them, and that I think is perfectly okay, because that advancement is also making the stents better and more applicable and probably have better outcomes. Protection systems, again, too, I remember the first carotids we did were angioplasty. We didn't even have a stent to plaster the stuff up against the wall. And the concern was that you liberated little bits of atheroma or clot at the time. And so the original idea was to put a protection system in which sat in the internal carotid artery and occluded it. And so diverted anything to the external carotid where we think it doesn't matter. We now have filter systems, which we think will filter out some of the embolic load. We also have what is known as endovascular clamping, which is to put balloons in the common and external carotid artery to try and stop the flow in the internal, so that when you put the stent in, no material gets to the brain. And then the latest thing is this TCAR idea, where, which, going back to Samira, is a way of diverting blood from the common carotid artery so that you reverse the flow in the carotid, so that any material then is removed. So the evidence, I think, suggests that the flow cessation or reversal is probably more effective at reducing those small events that Jerry talked about on MR scanning. But those devices are very much more complicated to put in and have their own particular problems and complications. So bottom line is there's some great equipment. We don't have an awful lot of evidence to show that one is better than another. But I think if you look at what we're doing now to what we were doing 20 years ago, it is a very different procedure and a much better one.
The other problem, Trevor, really is that we actually have very little evidence that any protection helps. And whilst it feels intuitive that it really must do, trials have really struggled to show that using any filter protection works. And certainly some of the earlier trials, particularly centers in Germany that recruited to them, routinely did not use cerebral protection. And it was an observation that, particularly again in the asymptomatic patients, there didn't appear to be a differential outcome, probably due to not being powered to look at that very particular question. But interestingly, into my inbox popped a paper just a couple of days ago from Turkey, where they've done a trial specifically. I haven't got the full paper yet, but this is a trial called the CASWEP trial, for those who may be interested, comparing stenting with and without protection. And they've again shown no difference in outcomes. We moved on to using the endo clamping quite a number of years ago, the balloon devices that stop the flow in the carotid artery. And as Trevor said, they are somewhat more cumbersome, but they seem to certainly give me the reassurance that if anything's going to stop clot from going to the brain, that will. And also, as Jerry will remember, particularly when Samira was working with us and afterwards, we did a number of these transcarotid revascularizations of the TCAR that's so big in the States now. We started doing them in Newcastle 10 years ago, something like that, but for a brief period of time. And again, that seemed intuitive, that if you get directly into the carotid artery without having to navigate through an atheromatous aortic arch and into the great vessel origins, you should hopefully knock off less plaque and send it up to the brain on either side of the brain, not just the side you're treating. And certainly TCAR, as it's called in the States, is getting great traction.
Yeah, it's Jerry. Can I come in quickly, John?
Yeah, please do. Please do.
Yeah, well, a couple of things. The first is I do have the advantage of opening up a carotid and seeing what it looks like inside. And there is a considerable difference between the acute carotids and the asymptomatics, where very often in the acute carotids, you've got, ruptured surface of plaque with sort of debris coming out of the plaque or clots on the plaque. And the more chronic asymptomatics, where the plaque's usually intact and smooth and quite fibrously capped. So, one could imagine that putting your stenting devices through the first type of plaque is going to potentially be much more dangerous than through the asymptomatic chronic plaque. So that it immediately suggests to me that stenting might actually have some advantage in the asymptomatic, where you don't have all that sort of debris to knock off. And I have to say, with the TCAR, which we probably did about 15 to 20 cases, I would think, Ralph, we actually got to the point of finding it pretty straightforward, but we didn't find that many people that seemed suitable, unfortunately. But as I understand it, that equipment is not available for us anymore, so we've more or less stopped doing it because it hasn't got its CE mark. Is that right?
I think unusually they brought technology to Europe, trialed it in Europe, took it away from Europe, and actually then did the further trials in the States, and then haven't really released it to the rest of the world again, which is really very unusual.
Yeah, but it does reduce all the risks of negotiating a atheromatous arch and a tortuous common carotid. So it's, I guess, watch this space. It's certainly an interesting device, and it combined that with flow reversal back into the femoral vein, of course. And even if statistically it didn't seem to reduce anything, I remember the little filter, you could look at what was lodged on it at the end, and there were sometimes quite worryingly obvious, macroscopically visible little bits of rubbish on the filter at the end, which presumably would have gone up the carotid if they hadn't gone down into the flow reversal down to the femoral vein.
Great. So I think we're just about creeping up to the hour mark. So I wondered if I just wanted to invite the panel if there's any sort of closing remarks they'd like to make, or any kind of summarizing comments, and then I think we'll draw the session to a close. So I don't know if anyone wants to jump at that chance. Go for it, Trevor.
Yeah, I mean, I'd say this is a good trial. It was well conducted. We were involved in it, but it was a good trial. I think the conclusions from it are reasonable. I think we have to remember that there are a couple of things in the background, which is the modern best medical therapy and how much difference that would make to whether any intervention, be it surgery or stenting, is helpful. It's a relatively marginal benefit in an asymptomatic patient, and that they certainly should, I think the take-home message for people not directly involved in this day in, day out is it should not be a knee-jerk reaction. There is disease in the carotid artery, it therefore needs to be treated.
I don't know, Ralph and Jerry, do you want to add anything?
I think that's a perfect summary as far as I'm concerned.
I agree. And I think just to add, you know, a multidisciplinary discussion is, and you know, we have a specific carotid MDT, which is very helpful for discussing these cases. And I mean, I haven't really talked about, you know, the technical case selection for stenting, because actually there's quite a lot of patients who are either not suitable for stenting or have quite a technically challenging option for stenting. So one of the things I think about the track record isn't just being good at doing it, it's probably being good at spotting which ones should or shouldn't be offered a stent, because some of them you might actually be taking on something that's rather too challenging, I guess. Would you agree, Ralph?
Yeah, I think case selection in almost every single treatment that we do is paramount.
Brilliant. So I think we'll draw the session to a close there. But before that, I just wanted to thank all of our everyone who signed up for the webinar and joined us. I think it's been a great turnout, and thank you very much to all of our panelists and to BSIRT and IR Juniors for hosting as well. So thanks everyone, and we'll call it a day there.
Thanks everyone.
Good night, everyone.
Thanks, John.
Bye.
Cheers all.
Great presentation, Talani. Well done.